Moving on to the third session, and that is on hypoglycemia in non-diabetes, the approach, workup and management. And as a speaker, we have Dr. Purushottam Chatterjee, a very renowned diabetologist.
Thank you, Dr. Purushottam, for allowing me to speak in front of you. I'm very grateful for that. So I'm going to talk about SOUL. Essentially, I'm going to talk about Rybelsus. And Rybelsus is an oral GLP-1 which we are very aware of. And I'm going to take a different tangent to it. All of us are aware. It has been launched quite a few years and all of us have used it. It's a sponsored symposium, so that's my financial disclosure. And there was a lot of excitement when it came because it was the first pill in a peptide. So if you look at why oral insulin is not manufactured, because if there is anything proteinaceous, it gets degraded by the protein enzymes in our stomach. And that's why it's very difficult to have something in protein in oral form. And that would, I would think, a big revolution with this is that binds with snack, and that's why it needs to be taken empty stomach. We are well aware how it has improved HbA1c and the weight. In my experience, I've presented that in IDF as well. And around 5 to 7 kilogram of weight loss is there if you continue on it. Some will be super responders. Some may not be super responders, but as an average, 5 to 7 kilograms of weight loss happens in HbA1c drops around more than a percentage or around a percentage in most patients if you persist in it. Now, when faced with what are we doing, there was some question about thyroid because thyroid also needs to be taken empty stomach, and oral Rybelsus we also say empty stomach and you have to wait for half an hour. So there's two tangent to that. If you are finding it difficult for the stabilize the patient's thyroid, then you should not change the timing of it. You should change it in the morning. Only after 1 hour of Rybelsus you can take it. But otherwise, what thyroid tablets wants is a 6 hours gap. So there is a huge gap in our life between lunch and dinner. So thyroid medication could come before dinner if you are not having a snack. So that movement is allowed because all the data is there with the 6 hour fasting data that is there with most molecules that is there. Over and above diabetes medication. So when we look at, can you close that door for me? The voice is echoing, please. If you look at any medications that we are looking primarily as an anti-diabetic, two important factor is there. See, it's like my son who's going to get married. I want him to get married to a girl. And then the girl must be well educated, perhaps good looking, perhaps have a lot of money, perhaps have a lot of societal associations and pressures and all that. So when we are looking at an anti-diabetic, primarily we are looking at anti-diabetic molecule plus pleiotropic effects, whatever else that we can take. And this era, we need to look at the cardiovascular outcome studies that are there, and that is what we're going to talk about, SOUL that is there. Now, if faced, all of us have challenges giving insulin and all of us have challenges giving injectable therapy, and faced with an option, will I take a tablet or will I take an injection form? It's far more easier for the patient to get convinced to take an oral molecule than to take an injectable. I'm sure all of us have our old techniques to convince people to go on injectable, be insulin, be any other molecule that is given injectable, and there is increased adherence. And we can understand that. Suppose I have to take an injection, I have to carry it with me, a tablet can be put in anywhere, and it's more discreet and it's more easier to follow. So you see that there is an acceptance of the patient, and if you look at that will help in improving HbA1c because adherence of the molecule is going to be far ahead. If you look at comparison of oral and injectable semaglutide, we know that the circulating levels are quite similar dose to dose that are there with oral injectable. Let's look at the various cardiovascular studies that have been done on GLP-1. So the first on the block was LEADER, which was also a Novo product. And most important thing that you see out here was that the hazards ratio, it was predominantly driven by CV death. So it was a 12% reduction. It was predominantly driven by the CV death. If you look at REWIND, which was a cardiovascular outcome trial with dulaglutide, there was a 3-point MACE, again a reduction of 12%, LEADER was 13%, and this was predominantly divided by the non-fatal stroke. That was the one that was driving this. So there was a difference. So this is around 13%. Now if we look at, I'll stop here and I'll say about what we've got about SURPASS CVOT trial that has come recently. It has said that it is equivalent to dulaglutide. That is all the data is. So dulaglutide is 12%, and you cannot extrapolate more. So what surpassed CVOT of Mounjaro said, I am equal to dulaglutide, which is 12%. That is what the data is saying, and that is what is non-inferior in cardiovascular study to dulaglutide. Now let's on that era look at oral Rybelsus where we are. So we have leader which showed 13%, we have dulaglutide which showed 12%, we have Mounjaro which is saying 12%, and now we look at cardiovascular outcome trial with oral semaglutide, which was an event-driven trial. So when we made an event-driven trial, we have pre-specified that this amount of events have to be achieved within the placebo and the main group, and after that we stop the trial and see the incidence of improvement of cardiovascular thing. When we look at 3-point MACE, we obviously look at non-fatal MI, non-fatal death and CV death. So out here they were titrated from 3 milligram, then after 1 month, as they said 7 and as they said 14, and it was an event-driven trial, and primary objective was that the oral sema improves the 3-point MACE as compared to placebo that was there. If you look at the demographics of this patient, it was mainly a more male preponderant patient with a 71 to 29% ratio, and other HbA1c baseline was around 8%. This was trial to look at patients with established cardiovascular disease or high risk renal disease or high risk risk factors that are there with peripheral artery disease or coronary artery disease or stroke. So if you look at the division of that, 70% at coronary artery disease baseline, cerebrovascular disease 21%, chronic heart failure 23%, and peripheral vascular disease, arterial disease of 15.7%. Concomitant medication will always be there, anti-diabetic medication will be there, and other supporting medication. And so one has to understand in this era, if you look at old UKPDS study and old DCCD trial, there was less medications. Now to prove any cardiovascular outcome benefit on top of this medication, that means the medication is really very powerful. Because पहले statin नहीं था, अभी statin भी देगा, ACE inhibitor भी देगा, सब कुछ देगा, SGLT2 भी देगा. उसके ऊपर अगर if you are giving something and it's showing benefit, then it has a more remarkable effect. So what it has shown is that it reduces the 3-point MACE by 14%. So I have given you a historical figure of 12%, 13%. And with an oral tablet, now you have got a cardiovascular reduction of 14%. This is important to note because oral tablets are far more acceptable commodity in Indian market and will continue to remain so. I don't think it will ever get phased out. Oral semaglutide will never get phased out. But more importantly out here is the division of the graph, and there is early separation of the graph very early. We suggest that the benefits start in much earlier that you can see that is there. And if you look at number needed to treat, when I say number needed to treat is how many patients I need to give a medication for to save one life or to save one 3-point MACE, and the NNT is 50. Are you waiting to ask me a question? No, okay. So then NNT means 50, that is there, and the hazard ratio is 0.86, which you can see out here, with a confidence interval of 0.7 to 0.96. So whenever we look at a hazard ratio, it should not cross the midline, and that is when it is significant. So if you look at 0.86, that is 0.77 to 0.96, that is significant, that is there because the confidence interval has not changed the midline. Now if you look at the individual 3-point MACE that are there, we have CV death, non-fatal MI and non-fatal stroke, and as you can see out in this forest plot, it's on towards the predominantly driven of this is the non-fatal MI that is there in terms of this. So why in one GLP-1 trial that is non-fatal MI, why is in one CV death, why is there non-fatal stroke? We don't know. Nobody has that answer. But the 3-point MACE out here, if you look at the 3-point MACE that we look at composite outcomes, that is 14%. And if we now look at subgroup analysis of the patient as Asian patients or patients we divided into more than HbA1c 8%, they have a better outcome at patients who have more than 8% and in an Asian group which is 27%. So the outcome is better, that is there, but though it didn't reach statistical significance, but it needs to be more power to look at more studies that are there, but there's an indication towards that is there. Now they looked at secondary outcomes. This has just been showed in the European Renal Association conference looking at renal data, and then they showed that oral sema is also reducing EGFR, and an improvement is there by 32% at 4 years that are there, and consistent reduction in annual EGFR that is there, though urine ACR has not been studied in this population, but that is subgroup analysis to it there. Now the question is, why do we see diabetic patients? I think most important factor is why you and me and all of us are doing this thing. We want to make a difference to our patient lives. And when we can make a patient to a different lives is when we should act to make a difference to a patient life. It's like I'm standing in my house and a snake has crept in my house. Shall I wait for the snake to bite me or shall I kill the snake first? So we need to actually get on top of things much before that has happened, because the things are ticking here and there. See, I'm wearing a tie. This tie is made of silk. This is what normal arteries are like. The lining of the endothelium is very silky and very nice. Nothing passes through it, nothing sticks to it. The moment the endothelial lining becomes diabetic, it becomes like Velcro, it becomes sticky. So your cardiovascular risk starts from the day, in fact, a little before you're diagnosed to have diabetic. So as astute clinicians, we need to look at medications which can reduce the cardiovascular risk and proven to have cardiovascular outcome studies, and which that oral Rybelsus has got a good memory. There is data that is there, and we need to, this is first line approved in India as well. Doesn't mean you need to go and prescribe every patient tomorrow first line oral Rybelsus, but keep that into consideration if the patient can afford after metformin, whether that is something that you can do. And if patients have any problems with SGLT2, definitely GLP-1 comes on top than anything else, because it's got a proven cardiovascular outcome studies. There's Pioneer real data which is due to be published, but it shows benefit, and it also shows that higher the HbA1c, greater the fall, which we all know. Higher it is, it will fall better. That is there with the patients. With that, and my presentations, are happy to answer any questions at the end. Thank you so much.
Thank you, Dr. Mithun Bharti, for your nice delivery.
Thank you, Dr. Bhartiya, for a very nice presentation. So, say a question from my side would be, we've now got several GLP-1 analogs. And when we first started, we were using GLP-1 analogs largely to lower body weight. So is the benefit that we are getting, say, from the newer ones, body weight related, or is it actually the molecule itself, or is it something else? Is how I perhaps would ask myself this question.
So I don't know is the honest answer, but I can make some didactic calculation what I will do in my practice. If a patient is extremely obese and has come to me and he's got diabetes, then obviously the more newer injectable ones will take precedence. There is no doubt on that. But somebody who's not morbidly obese and does not want to go on injections, then the oral tablets come into play. I would assume that by March, Novo Nordisk could also be kind enough to reduce their prices so that we have got quality medications available at affordable prices. That would be the marker that would be there. In patients who are non-diabetic, because if I now look at pure obesity practice, because if you look at even the Surpass data, or even if you look at, so both Mounjaro and injectable data that we are looking at, the effect of weight loss in diabetic is less. Even though everybody say 15%, 20%, the actual weight loss is 9 to 10% in a diabetic patient. So diabetic patients tend to lose weight less, more difficult. So if it is a pure obese patient and who has NASH, the data is of essence, which is injectable Wegovy. If he does not have, again there is obstructive sleep apnea, the data is with Wegovy. If they don't have NASH, then you can use either of that molecule who are morbidly obese and non-diabetic. If they are diabetic, it's a patient's choice, because you lose weight on this as well. So it depends upon what. Do we actually need to lose 15% to 20% weight loss for every patient? I don't know. I don't want to. This is my personal opinion. I don't want to lose 15% of my weight. Because the data in every trial that you look at, both Mounjaro and injectable, the primary outcome is 5% body weight loss. And the reason for that is all the NICE guidelines have said that if you lose 5%, a lot of your metabolic memory is reversed and it's good for your health. So all the data, all the primary outcome data is of 5%. So if I can lose 5% of my body weight with an oral tablet, I am quite happy with that. I don't want to fight 20 is more. I don't want to look like Karan Johar. I might want to be a little thin, but I don't want to look like what he was and now he's become a skeleton, or Sharon Osbourne who's become a skeleton with losing 20%, 25% weight loss.
Yeah, perhaps I may be hardy, but I don't want to look like Laurel. That's how it is.
Exactly.
Sir, I have one question that semaglutide reduce the weight or GLP-1 going to reduce the weight. Okay. How long it persists?
That's a good question. So I will ask you a written question.
Yes.
You are giving oral anti-diabetics to
Yes.
patients, SGLT2. How long will you give?
We are giving the almost lifetime.
It's the same answer.
But
Just because it is expensive, the question has changed.
But one thing is that because this group of drug is so expensive, it is not
answer that
possible for the poor people to continue all over throughout his life.
So my
get the effect.
suggestion is that discussion should not be. Can you close that door, ma'am, please? That discussion should not happen after prescribing the drug. That discussion with the patient should happen before prescribing the drug. I tell my patients, 1 lakh taka lagbe, bosoro. Parbe na na. If you
In
cannot
your
afford, I don't
experience,
put.
what do you find? Say for 2 years, 3 years, after that it gives the plateau, then it doesn't reduce the weight or reverse the weight.
So that's a
Weight
good
gain.
question. Now, let's look at from a practical point of view. From a answerable point. What time is it? I'll just keep a note of my time because I have to catch a flight.
Sorry, they have done drug holiday trial.
Okay. So let's look from a pragmatic point of view. Any overweight person, you tell him to do any physical activities, there is no motivation factor. There is no motivation. If he loses some weight, he may change his lifestyle also. So in some patients, I have stopped oral Rybelsus and they are fine with it. I have some patients. But that also depends. His lifestyle was so poor. Now he lost 5-6 kilograms. He decided to take his life in his own, decided to change everything. There will be few. Same that will do for injectables. If you look at injectables, there is data. If you look at the trials, that even if you look at Wegovy, even if you look at Mounjaro, they said the moment you start stopping treatment, the graph diverges. And the data is there of 2 years and the data is diverging. For Wegovy, the maximum weight loss is 16.7%, which you achieve at 2 years. And after that, it stays at 1 year, 68 weeks, and it stays like that at 2 years, at 4 years. Moment you stop it, you tend to gain weight. Same for this. Because same for oral Rybelsus also. Same for any anti-diabetic medication also. You stop any anti-diabetic, sugar will go up. So that cost, I agree, 100%. It is our duty, our onus to tell the patient the cost.
Sir, if time allows, my second question, just small brief question. Sir,
What I would perhaps say, supporting Dr. Bhartia, is that both these groups of drugs, semaglutide as well as tirzepatide, have shown basically on a drug holiday what happens. Okay, so there is some weight regain happens, and that regain actually takes time. It takes more than a year for you to basically, as even Dr. Bhartia mentioned, do I really want to lose 15 kilograms of weight? That is one thing. So you may not need to basically give the top dose of the drug. You may settle for a smaller, lower dose, which will be cheaper, which will be value for money.
7 milligrams. You can play around as well unofficially. A little bit, 7 days ka 8 दिन, 9 दिन, थोड़ा बहुत इधर-उधर कर सकते हैं when is there. Unofficially, you can do that. It all depends what you want to do.
So this group of drugs mainly popularized due to the two important facts, that is cardiovascular benefit point of view. Number two, it reduces weight, other than the blood glucose control. So we find that it reduces significant amount of the weight. But we want to know one important fact. How does it reduce the weight? Because it differs it from other drugs.
Very good.
We are using the several molecules
Sir,
in
I will
our
answer-
planet. But like this molecule, no one molecule reduces the weight so much. You consider the tirzepatide, we are reducing the 25%, 30% weight
Dada.
loss, but simultaneously the nutritional hazardment, it reduces the 5% of muscle mass, which is sarcopenia, which you cannot revert it back so easily.
Okay, I will answer that. I have a flight, but I'll do a very brief answer on that. There is something called hedonic drive. There is something called executive function. Hedonic drive is Rasgulla samne hai. I love Rasgulla. I need to control it. I can't control it. That is the hedonic drive. Executive function is that you can control it. So these drugs increase the satiety of your stomach. So mini bariatric, you can look at it, and reduces your hedonic drive that is there. Some would be super responders, some would not be super responders. There is loss of visceral muscle mass, but there is loss of muscle mass is comparatively less than the fat loss. Yes, there will be sarcopenia. Yes, the patient has to be taught how to do exercises, isometric exercises for the weight loss. And yet, yes, that's why I said 15% is not my aim for my patient. That's why I want 5%. Get him to regain his muscle mass, get into exercise, and then aim for more. I don't want to reach the moon today. I want to climb stairs to reach the moon. I don't want to take an elevator. Thank you.
Yeah, you have to live the journey with the patient.
Yes.
I think that's the most important thing, really speaking. Dr. Bansali, yeah.
What is the mechanism of cardiovascular benefit by GLP-1 analog? Because cardiovascular benefits start very early as compared to weight loss. And in other way around, can we start this molecule in normal weight patient with cardiovascular disease or high risk already existing cardiovascular disease?
So the second answer is so you can start anything. There is no rule that you cannot start, number one. But then you need to think, if I make this patient a person who's not normal weight and he actually loses 20% of body weight, what am I doing to this person? And if there's an alternative that I can give, obviously I'll consider the alternative. It is a proven benefit with cardiovascular outcome studies. So only proven is this and SGLT2. और कोई proven नहीं है. Metformin is old age चल रहा है, क्यों चल रहा है पता नहीं, लेकिन चल रहा है. अभी कोई इसको छेड़ेगा नहीं. शादी हो गया बीबी से, अभी कोई छेड़ता नहीं है. तो वो चल रहा है. लेकिन SGLT2 and GLP-1 are the only proven CVOT trial. So from a cardiology point of view, sir, if you want to reduce his cardiovascular risk, only these two options are there that we can look at. Now you want to look at, do you want for a normal person to lose a lot of weight, or you want him to lose 4-5 kilograms, then this might be an option, or an SGLT2 might be an option. The mechanistic action is unclear because, I would say is unclear because all the GLP-1 trials have shown reduction of 3-point base by different mechanisms. Some by reduction non-fatal MI, some by non-fatal stroke, some by CV death. So exactly if you ask me how, I don't know. There are various theories that may improve atherosclerosis, concomitant weight loss, concomitant blood pressure, blah, blah, blah. But if you ask me one theory which explains everything, I don't have an answer, sir.
One plausible explanation could be the reduction in the inflammatory marker. So as the anti-inflammatory role, perhaps the cardiovascular protective effect starts early. So thank you very much, Dr. Mithun, for the excellent presentation. So thanks, and we close this session.
Thank you, Speaker. Thank you, Chairperson. Now I would like to request Dr. Sanjay Sud, sir, to please felicitate our Speaker and another Chairperson.